Hi, good afternoon. This is Dr. David Miller. I'm an orthopedic surgeon with OrthoVirginia in central Richmond, Virginia. A little bit about me. I grew up south of here. I went to University of Richmond. I took an Army scholarship when I went to Georgetown Medical School. I did my internship in Hawaii, and then I did a residence. Then I went to Desert Storm as a flight surgeon, and then returned to Walter Reed to do my orthopedic training before I returned back to Richmond. But anyhow, today we're going to talk about something that's very near and dear to my heart, hip replacements. And so how do we know when it's time for a hip replacement? So we want you to have an informed decision. Hip pain is very common, but you don't always need surgery. One of the things we need to do is decide whether or not your pain is coming from your hip or elsewhere. We'll talk about some of the conservative treatments and our goals and next step that you need to take. The hip is a ball and socket joint. It has a ball, which is called the femoral head, that sits inside a cup, which is the acetabulum. If you notice on this x-ray, the normal hip has a space there. And that space is the cushion. It's the cartilage or the cushion that allows for smooth movement. When that wears, you develop what is in arthritis. So loss of cartilage is arthritis. And the end state of loss of cartilage is what you see on the other x-ray, which is bone on bone. So anybody who has a healthy joint, they have a good motion, it's pain-free, you got a nice space there. There's common causes for hip pain, that's surrounding the joint itself, but you can also have pain into your hip that could come from your back, or you could have pain in your hip because you have bursitis. But those that are having pain that are coming from the hip itself, the most common is osteoarthritis, or what we call wear and tear arthritis. Rheumatoid arthritis develops loss of cartilage because the capsule around the hip becomes inflamed and it deteriorates the cartilage, which then leads to arthritis. Avascular necrosis is a condition that is caused by loss of blood supply to the femoral head. And when that happens, the bone dies and it collapses. Causes for that can be medications like steroids. You can see it during pregnancy, or you can see it during trauma. Alcoholism can cause that. So that's another reason. Injury to your hip, if you were in an auto accident and you dislocated your hip, you're prone to developing arthritis later in your life. Congenital, meaning it's developmental. You have what we call hip dysplasia, where the hip joint doesn't rest in the socket like it should, so it causes high contact pressures, which wears away the cartilage as well. So there's lots of conservative treatment. Certainly, we can try physical therapy. Anti-inflammatory medications, Tylenol is one. Tylenol adversely can affect your liver. The non-steroidal anti-inflammatories, such as Motrin, Advil, Aleve, they can bother your stomach, your blood pressure, your kidneys. And then the ones that I write prescriptions for that are actually usually double the dose that you can get over the counter. The best way to take an anti-inflammatory would take it for a period of 5 to 6 days to get rid of the inflammation, and hopefully you can come off of it to allow your body to heal. We get into trouble when we take those long term. All these medications are poisons. They have their side effects. Certainly, the lifestyle modification is important. You want to keep the weight down. You want to keep active, the proper diet, and smoking modification. Smoking can cause problems. And then when all these things stop working, then that's when we actually consider surgery as an option. So signs that you might be getting there, you have persistent pain, particularly pain at rest or at night. There's difficulty with activities of daily living, particularly stiffness in your hip to the point that you're unable to tie your shoes or clip your toenails. You lose the ability to internally rotate your hip and then externally rotate it, and that's if it's affecting your ability to tie your shoes or clip your toenails, then that's becoming significant. Certainly, loss of sleep can affect your mood. Then, x-rays showing bone-on-bone arthritis. We know that, I certainly don't push early surgery, but we know that the better shape you're in, the better you're going to do. So Those people that tend to use a banister prior to surgery tend to use it afterwards. Those that have better motion tend to have better motion afterwards. But you want to make sure that you have a significant amount of arthritis before you consider surgery as an option. What can a hip replacement offer? What we like to have in orthopedics is what we call the forgotten joint, meaning you forget what side your surgery is on. That would be ideal, unless, of course, the other one's arthritic. It's more often you'll see that in the hip than in the knee. I can tell you that the most cost-effective procedure we do in medicine today is cataract surgery, meaning those people that can't see because they have cataracts and they have the surgery, they're no longer a burden to society. The same thing with hips. Hip replacement's number 2 and knee replacement's number 3. So it can get your life back, and it's a very cost-effective procedure. It improves your mobility. Often asked is how long will these last? Well, historically we talk about 15 to 20 years or better. That's based off of what we did 15 to 20 years ago. My feeling with the newer plastics and the newer bony ingrowth and things that we can do now to make these last longer, assuming that we avoid the early complications, that they may last longer, maybe a lifetime. I'll be dead or retired before we figure that out, though. So who's a good candidate? We monitor severe arthritis on imaging. We know that those people that don't have a lot of arthritis on their images, even though they may have some mild arthritis or may have arthritis secondary to MRI, don't do as well. These individuals have failed all the conservative stuff. Good health. So the better shape you're in, the better you're going to do. So we want to make sure that your heart is healthy, your lungs, anything that we can improve prior to surgery, we want to do. And certainly you need to be really motivated to do rehab and recovery. Stop smoking. If you're smoking, want to stop that. We want to make sure you bring the weight down. But do it in a safe way that you're not starving yourself to get there and become malnourished. Actually, you can be overweight and malnourished. When we consider surgery, we certainly talk about using minimally invasive techniques. You can have this surgery done through the back or posterior lateral, or what I use is the direct anterior approach. There's a lot of controversy over which one's the better way to go. I prefer the direct anterior approach. I feel like I can get up and going a little bit better. Individuals, a year out, it probably doesn't matter which you did. I also prefer it because when I do surgery, I'm able to use an X-ray machine to know exactly where the components are being placed. And it also helps me with leg length. So I prefer the direct anterior approach. I started doing it almost 15 to 20 years ago now. And even patients that did real well doing it through the back, I feel like they came back and said that it was an improvement over their previous surgery. Hospital stay, I do a lot of surgeries now, outpatient, assuming you're healthy enough and your height-weight ratio or your BMI is under 40. I do these outpatient. I probably do about 60% or better of my surgeries outpatient same day. If it's done at the hospital, it's because we want to make sure that we're monitoring things. Usually it's because of heart and not necessarily age, but it's your overall medical condition. We get you up right away. We get you up. If we do it same day, so you need to be able to get up and down stairs because you need to be ready to make sure you can do that. If you're in the hospital, you get you up the same day. We usually do the stairs the next day, and the next morning you go, assuming everything's going well, which is about most of my patients leave the next day. Usually driving at 2 weeks, use a walker for the first week or two, and then we'll start returning back to your activities. It's hard to say, often they'll ask you, when do I get back to normal? Well, oftentimes these patients were normal when they started. So it's hard to determine where that crossover is, but we start activities pretty quickly thereafter. There are risks, of course, infection, bleeding, risk-related anesthesia, although be it very, very low. We talked about the lifespan. Certainly the younger you are, the more likely it is you're going to be more active on it, and the longer you're going to live, so that you may, have a better chance of wearing things out. Certainly physical therapy is important. Oftentimes with hips, we don't need a lot of physical therapy, but if we feel like you do, then that's the option. We try to get you to physical therapy soon, right after surgery. So a lot of patients get pain relief from this. There's a high satisfaction rate, And we want to get you back to doing the things that you want to be doing, walking, hiking, golf, bicycle, whatever it is that you'd like to do, get back to your normal activities. You can wait too long. Like I said, the better shape you're in, the better you do. As you slowly start to walk and you end up in a wheelchair, then it's probably too late to do surgery. So we want you to, it's not that I don't care about your pain, but I do care about your activity level. If there's any questions, feel free to ask me now.
Thank you so much, Dr. Miller. We will be taking questions that people ask live, as well as questions that were presented earlier. So if you are watching this live on Facebook, now is the time to ask your questions in the chat. We will answer many questions, but not all questions will be able to be answered. So our first question is, what kind of anesthesia is used in hip replacement? Is general anesthesia always required?
No, it's not. So oftentimes, if we're doing this surgery at the hospital, we're doing a spinal anesthesia. If we're doing it same day, we'll do it general anesthesia, because sometimes it takes a long time for you actually to get over the numbing sensation from the spinal anesthesia. So if it's done outpatient, it's usually general anesthesia. If we do it inpatient, then we usually use a spinal.
Thank you. You spoke about using the anterior approach. What does that mean?
The anterior approach means going through the front of the hip, as to what I used to do more traditionally was through the back of the hip. I feel that there's a lot of talk about it being muscle sparing and smaller incision. And in my mind, it's not all that. I'm just not operating through the muscles that you tend to use to walk with, that being your deltoid or your glute muscles. If you operate through that, you tend to use those more to walk with, so it's more sore early on. If we operate through the front, more of a muscle sparing type of approach, then those muscles are used like kicking. So I think that it helps to get up and move a little earlier. And again, I like it because it gives me better visualization during surgery.
Thank you. If pain in the hip comes and goes, is it time for a hip replacement? Or should the pain be constant before you have a replacement?
Oftentimes, hip replacement can be fairly constant, unlike knees. It's interesting that during COVID, when I had to stop doing elective procedures, the patients that tended to come back earlier were my hip replacements. And I think it's because it's harder to get away from hip pain than it is to get away from knee pain. But that being said, I mean, generally arthritis is a come and go type pain. Now, when I say you have good days and bad days, good days and bad days, and over time, the good days become far and fewer between. And again, I don't care about your pain. Not that I don't care. I do really care about your activity level. So if it's starting to slow you down, you're becoming deconditioned, and then it makes it just harder for us to get you back to where you were before.
Thank you. How long does the surgery itself take?
It takes about an hour, usually, give or take. It's about an hour.
Thank you. How long after a steroid shot can I have surgery?
Yeah. Thanks for asking that question, because I admit that is one of the treatment options. Certainly one of the things we can do to hold off surgery is to consider a cortisone or steroid injection into the hip. This is often done under fluoro, so I can't do that in my office. I have some partners that use a fluoro machine in the office that they can set that up and do an injection. I call those injections honeymoons, because we all know how long a honeymoon lasts, right? Some longer than others. So if we get a good long honeymoon, great. 3 months or 6 months later, we can re-inject you if need be. But if you've had an injection, we want to wait at least 3 months before we consider surgery as an option because of risk of infection.
Thank you. What can I do to prepare my home for my recuperation?
Right. So you want to get rid of any obstacles. I mean, certainly, throw rugs, things that might get in your way. You're going to be using a walker for the first week or two. So you want to be able to make sure that you can get around things and be mobile in your house. You will need to be able to do stairs, so you don't have to have a lift or anything. Oftentimes, if you can move your bedroom downstairs, it would be ideal, but a lot of patients aren't able to do that, so they have to mobilize the steps. But the whole idea is the reason why patients do better when they go home as opposed to rehab is because you get more rehab by going home, because you have to get up, use the restroom, you have to go up, you maybe get the mail, prepare dinner, go to dinner, so you tend to move around more when you have to do things for yourself.
Thank you. Do you have tips on mentally preparing for surgery?
I think being informed, if you're that type of person that needs to be informed, either, making sure your doctor answers the questions, you certainly can do a lot of internet searching. We have a patient portal that if you do have questions prior to surgery, then you can ask the team, and the team will relay that to me, and we can, get your questions answered. So I think it's in mentally and physically prepared. Certainly, sometimes we'll do some therapy prior and just getting ready to get going.
Thank you. What are hip replacements made of?
They're not sugar and spice and everything nice. They're made of titanium, usually on the stem. There's a titanium cup, but the bearing surface between the head, I usually use a ceramic type of head with a polyethylene or plastic insert. The reason for that is we've had other bearing surfaces in the past that didn't do really well. I initially had done some with ceramic on ceramic, which is a very good wearing surface, but there was hip squeaks, which was not tolerated well. Then we did metal on metal, which was bad because that disperses metal ions to the soft tissues, which isn't good. So I think the home run right now is the plastic insert with the ceramic head, and that seems to give us really, really good long-term wear. So mainly those two, and then titanium is what I use.
Thank you. Can you give a few more details about the recovery after a hip replacement? For example, how long until someone can work from home? How long might they be doing physical therapy if they do go to physical therapy? How long before the hip stops hurting?
Well, certainly with each patient that varies. Okay. So and it depends on, work means to you. Certainly if you're working at home, I tell patients they can begin working right away as long as they're not needing narcotic pain medication for their pain. You certainly wouldn't want me to operate on you if I was on narcotics. So I don't want you answering or doing difficult problems. So it's really, if you're working from home, it's not when you don't need pain medicine. You can begin driving at 2 weeks. And if you're just going into the office, that's fine. Certainly it varies. If you're doing heavy construction, and it may take 8 to 12 weeks to get back doing that type of work. And it depends on how much time you have to take off from work. For instance, if you're a farmer and you have to do your stuff, a lot of patients will get back to work earlier. But if you work in construction and you have 3 months, you often will take it. It depends.
Thank you. If someone lives alone, is recovery from a hip replacement something they can do on their own, or do they need someone to stay with them?
I'd like them to have somebody stay with them at least 72 hours right after surgery. I just think that's the safe thing to do. It's not like there needs to be somebody there to do anything for you, but I just, for my comfort, and I think for their comfort, something for 72 hours would be fine. They're not going to need a lot of help. And then somebody, looking on them would be fine.
Thank you. After a hip replacement, are you able to do things like play pickleball and tennis and other sports, or will that mess up the replacement?
Yeah, I was always a big advocate on holding off on high impact stuff. I recently had one of my mentors come and give a talk here in Richmond, and he talked about letting patients do whatever they wanted to do. Pickleball is certainly within the realms of something like to do. Generally, if you're a tennis player, I'd say doubles as opposed to singles. High impact stuff like jogging, I'd like this hip to last a long time. I'm sure most of my patients would too. But do I have patients out there that are running on their replacements? Yeah. If so, you want to wait a long time so that it's well healed, which could be 6 months to a year.
All right. Thank you so much, Dr. Miller. Would you like to close?
Well, again, this is probably my favorite topic. I love hip replacements. I love hip replacement patients afterwards. And I'm just glad that you guys could spend some time with me so I could talk about it. So thank you.